The manual technique of subcision starts marking the visible inward-facing lesions with the patient in an orthostatic resting position. The use of tangential overhead lighting is very helpful for highlighting them. With the patient lying on their stomach, the marked lesions and surrounding areas are infiltrated immediately below the derma using an anesthetic solution. 10 ml syringe must contain 9 ml local anesthetic 1%, 1 ml sodium bicarbonate and 0.2 ml of epinephrine 1 to 1000. After waiting 10 minutes to achieve a good level of ischemization in the area to be treated, the skin is pierced with the device at an angle of around 60 degrees, about 5 to 10 millimeters from the margin of the largest axis in the drawing. These movements are varied in direction until there must be no resistance to the movement of the device. The procedure is repeated from several access points until the whole area to be treated has been covered. The free hand carries out a gravity maneuver, 5 to 10 centimeters cranially to the lesion, pushing the tissue in a cranium-caudal direction to highlight any residual adherence. If necessary, treat the areas that still show partial retraction again. At the end, the area is manually compressed for about 5 minutes to stop any dripping from the skin access point and limit the size of the hematoma. Antibiotic prophylaxis was always carried out and commenced 24 hours before treatment. After the treatment, the use of restraining elastic sheaths was compulsory for 1 week 24 hours per day and highly recommended during the first month. Lymphatic drainage or pressure therapies were also advised to reduce the postoperative phase and accelerate a full recovery. No other therapies or techniques were allowed in the treated area. After treatment, painkillers were allowed, although generally not necessary.